Welcome to our last in this series of National Lunch and Learns. Our focus today is on respiratory genomics. And as you can see, we're looking at familial pneumothorax. Now, this is not going to let me move my slide, is it? Apologies, everyone. My computer is playing catch up today. So there we go. Okay. My name is Anita Murphy. I'm the lead nurse for the East Genomic Medicine Service Alliance, and obviously not very technically minded, as we can see. I'd just like to start off by saying thank you to both of our presenters for taking the time and effort to put together this presentation for you today. This is a series of Lunch and Learns which are part of a national collaboration of the Genomic Medicine Service Alliances. Our aim has been to highlight the impact genomics has on patient care, to try and support that equity of access and aiming to increase genomic literacy amongst clinical staff. And just briefly before we start, I appreciate that some of you may not be familiar with ordering genetic tests. So this is just to highlight to you that we order tests through the National Genomic Test Directory. It's commissioned by the NHS in England, and it sets out the eligibility criteria and provides guidance on which patients may benefit from genomic testing. So I've just taken the page out on familial pneumothorax just to show that to you. And just to make you all aware, the National Genomic Test Directory is being digitalised, and I struggle with that word, so it will be available later this year in that format. There will be education and training sessions ahead of that change, and I know that some of the GMSAs have run them already. Your details will be on our database if you've agreed to share them with us, so you will be sent out information on future training events. So let me move on to our speakers. So today's presenters are Katie Parrot and Stefan Marciniak. Katie is a physiotherapist by background. She has extensive experience working in respiratory care, including in a plural ACP role, and Katie became a consultant advanced clinical practitioner in 2023. She is currently the lead for the respiratory advanced clinical practitioner and clinical nurse specialist for Lincoln, Boston and Grantham. Stefan is a professor of respiratory science at the University of Cambridge and an honorary consultant respiratory physician at Addenbrooke's and Papworth hospitals. His clinical research focuses on pleural medicine, especially the genetics of pneumothorax. Now, I'm going to stop sharing just there because, Katie, you're going to take over, I believe.
I've been asked to start the presentation today with talking about the signs and symptoms of spontaneous pneumothorax. That's the first slide. And then I'm going to give you some details on a couple of, it's a set of brothers who the team in Lincoln have met over the last couple of years, and just a bit of their journey through their pneumothorax history. So let's see if it'll move. There we go. So I've purposely put the typical signs and symptoms of spontaneous pneumothorax, and I haven't specified whether it's secondary or primary, because most of the patients present in a fairly similar way, so it doesn't matter whether it's secondary spontaneous or primary spontaneous. The underlying cause makes a the underlying background makes the difference between primary and secondary, but actually when they present with a pneumothorax, quite often the signs and symptoms are similar. So often the patients will describe a sudden pleuritic type chest pain, so it's often sharp in nature and usually unilateral on that one side where we find the pneumothorax, and it's often worse with inspiration as well. Patients sometimes, in a fair few cases, report sudden onset shortness of breath, which can be short lasting or can actually be persistent throughout. So that's one of the considerations to take into account. And then when we come to looking at the clinical findings when you're assessing a patient, the next signs and symptoms are the ones that you may find. So it's either absent or reduced breath sounds on the affected side. So if you're unsure, just make sure you check and double listen on whichever side and just compare both sides. Sometimes there may be anatomical reasons for that, and that might be normal for the patient as well, but actually absent or reduced breath sounds on the affected side is a common finding. When it comes to percussion note, so you get hyperresonance. So that's where when you're tapping on your finger, it sounds more hollow underneath, and that's because of the air that's there. So often if you see anybody with a pleural effusion, it'll feel quite dull because the fluid absorbs that tapping feeling, whereas actually when there's air there, it feels more open and airy underneath your finger. You get reduced chest expansion, so when you put your hands on a patient's chest, you can get less movement on the affected side, especially if it's a larger pneumothorax. If it's a small pneumothorax, you probably don't necessarily feel that. And then in some cases, patients can become cardiovascularly compromised, so presenting with tachycardia and hypoxia in the more extreme cases. So then on to the, excuse me, a couple of case studies. So we've got brother number one, which is Edward. So this has all been anonymised, so we haven't got their true names in case anybody's aware of them. But Edward was born in 2006 and he's the eldest of the two brothers. When we first met him, he was 5'7" and weighed about just over 8.5 stone. So not overly tall, but he was a very slim, very, very slim build. From a past medical history side of things, he had occasional constipation and he had some anxiety concerns, and he complained of joint hypermobility as well, and he wasn't on any regular medication. When we met him, he'd just started in a sixth form college, but prior to that he'd been homeschooled, but that doesn't make a huge amount of difference to him and his presentation. Case study 2, so the younger brother is called Luke, and he was born in 2008, so there's about 2.5 years between them. When we first met him, he was 5'5", so a little bit shorter, and weight was 7 stone 9, so again a little bit lighter than his brother. He was under neurology for investigation of tics, but I haven't seen anything to show any outcome of that. He also reported that he had clicky joints at times and some stretch marks, which may become a bit more relevant as we go through, and again no regular medication. From a family history point of view, nothing exciting really. So his mum was only 5'3", so not overly tall, and had no history of pneumothorax on her side of the family. Father was 5'10", and again no history of pneumothorax, and neither had any significant past medical history either. Paternal grandparents had type 2 diabetes, and their maternal grandfather had some heart troubles and had heart surgery. So nothing of any significance that we could tell from a pneumothorax point of view. So we'll have a little look at a bit more detail of Edward, so the elder brother. So we met him first off when he was 16, and that was in January 2023. And he presented to A&E with a left apical pneumothorax, which the plural team met him, and we decided for conservative management because it was only fairly small. And then a week later, that on X-ray, that had resolved. A couple of months later, on the 10th of June, he presented to ED again because he'd had some chest pain and he was a bit worried, but the chest X-ray was normal. And then just less than a month after that, he presented again to ED with left apical pneumothorax, and again conservatively managed. But at this point, we realised that this was a second presentation, so we better refer him to the thoracic surgeons for advice and input. So we'll have a little look at a couple of his X-rays to start off. So this one's on the 3rd of January, and your screens may or may not show the good enough resolution for this. But he has got a tiny little left-sided apical pneumothorax, which you can see when I draw my line on there. I don't know if you can then pick that out when I flick back between the two. And then on the 5th of July, it's slightly bigger. So I'll give you a second or so to have a look. And then that's the floral line there. So it just gives you an idea. They're not very big. And the second one was a little bit bigger. So then he went to thoracics in December 2023, and they made the decision at that point to have a watch and wait approach. So he got offered surgery, but actually he decided to wait and see if he was going to have another one again. Then comes around to the 8th of February. So at this point he was 17, and he came in and he again presented to ED with another left apical pneumothorax, but it doesn't appear he had any follow-up at that point. So I suspect we didn't get told about him as a pleural or a respiratory team, so he didn't have any follow-up. So then he re-presented on the 8th of August. So there's no evidence as to whether that resolved or actually it was persistent up until August, but we didn't meet him in the in-between. So there's an assumption, I suppose, that it did resolve because they had done in the past. But when he came in on the 8th of August, it was quite significantly bigger, and I've got an X-ray on the next slide to show you. So we put in a chest drain, and then on a couple of days later, he was transferred as an inpatient to the thoracic unit that we use at Nottingham and had a left VATS embolectomy. So this was the 8th of February, so it's a little bit bigger, but we didn't complete any follow-ups, we weren't aware of him. And then on the 8th of August, I think you'll be able to see that pleural line at the edge, and my red line is quite significantly bigger than on the other slides that I've shown you for his x-rays. So then when he'd gone to Nottingham for his surgery, he was discharged a couple of days later, 14th of August, with an ambulatory bag in situ. He went back on the 27th of August for his outpatient appointment there. The pneumothorax had resolved. They took the drain out, and within an hour, unfortunately, the lung had gone down a little bit again, but they decided again for conservative management. And then at follow-up x-ray on the 13th of September, it had resolved. And then unfortunately, again, he presented to us on the 28th of July just last year, again with a small left apical pneumothorax. So the surgery hadn't quite done its trick, but then within just less than a month, it resolved again. And actually, we haven't seen him since, which is a good thing for him. So that's the story. Oh, a couple of x-rays again. So that's him with his large bore chest drain post-surgery. And then that was the one that was attached to the ambulatory bag. So you can see at 9:44 for his outpatient appointment, his lung was up. And then unfortunately, at 10:44, the lung had come down just at the top there, as you can see. There we are. So that's the history of Edward, the elder brother. And then we've got Luke, who is the younger brother. So again, he presented to us when he was 16, and this was just January last year. So he he went to his GP with some chest pain, who sent him to their local UTC, which was a town outside of Lincoln. He had a chest x-ray and was found to have bilateral pneumothoraces. So he got sent straight to ED, Lincoln County. And they monitored him. They spoke to the on-call respiratory consultant, because I think it was quite late in the evening, who said monitor him overnight, and then we were informed about him the next day. So when we saw him, he then had a 12 French drain popped in on the left-hand side, and within a couple of days he again was transferred to Nottingham and he had a right VATS, pleurectomy, bilectomy and pleural abrasion. So that's some surgery to help with preventing recurrence. The left-sided drain was removed, and he had a very small left apical pneumothorax for conservative management on the 3rd of February. And then on the 4th of February, he went home with the ambulatory bag for the right side. 11th of Feb, the left is resolved, and on the 18th of Feb, the right is resolved. So again, some more x-rays. You can see there that left-hand side was quite a bit bigger than the right-hand side pneumothorax. And then there's a bit of a CT here. It hasn't come out, hasn't shown up quite as well as I wanted it to. But there is a bit, I don't know if you can see my cursor. If you can, hopefully. There's a bit of a pleural edge at the top of the right-hand side, and a bigger one on the left there. So unfortunately, that's not as clear as I wanted it to be. So we then, he was under surgical follow-up, and then on the 7th of June, he presented again with a right apical pneumothorax, which was conservative management. And then it gets a little bit woolly around here because thoracics were involved, we were involved. So thoracic follow-up showed that it hadn't resolved on the 23rd of July, but then by the 15th of August it had. And then he had a further left apical pneumothorax on the 30th of September, which roughly, well, a week later, that had resolved. He then had some thoracic follow-up in October, and he was offered a left-sided pleurodesis, surgical pleurodesis, but he declined, and they're doing a watch and wait approach. So if the pneumothorax either side reoccurs, then we'll refer him straight back to the surgeons at that point. So they're the two cases. And then again, this is Luke's chest x-ray. So you can see there the pleural edge. And then 30th of September on the other side, on the left-hand side. I've just highlighted it a little bit because it looked a bit messy when I put the red line on. But hopefully you can see a pleural edge within just by his clavicle there. So genetic tests and investigations wise, so there's a slight bit of difference between the two of them, and these might make, hopefully Stefan will be able to fill in the gaps a bit with his presentation. But from my point of view, we referred Edward to the genetics team, and he was seen on the 14th of November 2024. So as a team at Lincoln, we'd done the alpha-1 antitrypsin, and that was normal. He'd also had a normal echo. His height at the point of seeing genetics was 177, and he was a little bit heavier. His arm span was longer than his height, taller. I don't quite know what the word is there. Eyes wise, he'd had ophthalmology assessment and had no abnormalities found. He was found to have a high arch palate and a normal uvula, which is your dangly bit at the back of your throat. And then he did have evidence of arachnodactyl, which is long slender fingers. And there's a couple of tests. So it's putting the thumb and fifth finger around the wrist, and if they overlap, that's positive. But his thumb test was negative, which is where the thumb goes across the palm and you make a fist and it pokes out the other end. And then so that was Edward. And then with Luke, because we sent him straight to thoracics, we didn't have a lot of follow-up with him at Lincoln. So actually we didn't refer, and it appears that Nottingham didn't refer either. So there's no evidence, or from his GP record, there's no evidence of any letters or assessment from a genetics point of view. However, after speaking with Stefan more recently, they've now been referred to his service for discussion. So and that's all my bits. So
thanks very much, Anita, for the invitation. Thanks, Kate, for a fantastic presentation of a sort of patients that we'll see, and thanks for everybody else who's come to listen today. So what I'm going to try and do in the next 15 minutes or so is introduce you to the most important genetic disorders. Now you might think, well, these are all rare disorders, why should I care? Well, just remember, about 7,000 people, there are about 7,000 different rare diseases. Several hundred of them are respiratory. Most of them are actionable. If you make the diagnosis, you can make them live longer, or you can increase their quality of life by introducing early treatment. And as you'll all know, 2 days ago was 28th of February, which is Rare Disease Day. So I hope you celebrated. So what we're going to talk about is the variety of diseases that can present as pneumothorax. So if you pick a random person off the street, the risk of having a pneumothorax is quite low. It's about 1 in 10,000. So it sounds quite rare. But if you pick a person who comes to your clinic who's got a pneumothorax, 10% of them will have an affected family member, and that makes it familial pneumothorax. And this can be a first or second degree relative. It can be a brother, a mother, a child. It could be a cousin. As soon as you've got a history that there is somebody else in the family affected, your antennae should go up, and you should start thinking about, is there a rare disorder here that I could be diagnosing? This was a nice review written by Rachel Scott, who was one of my medical students. And if you want to Google it, it's in Thorax from about 8 years ago, but it's still fairly relevant. And what she's done is divided these patients into 3 groups. There's one where you get defects of a signaling pathway called mTOR. You don't really need to know much about mTOR apart from the fact it's mutated in a variety of cancer syndromes. And there are a couple of disorders that are inherited because of defects in mTOR signaling. There's a whole bunch of them when there's a defect in the extracellular matrix, the glue that holds your cells together. So a true connective tissue disorder. And then finally, at the end, there's probably 2/3 of these patients we still don't get a diagnosis. And that's because either they have got a disease that we haven't yet discovered, and we're still, from whole genome sequencing, discovering new cause of pneumothorax, or they've got a polygenic cause. That is, they've got more than one broken gene that together increases the risk of pneumothorax. We're going to completely ignore polygenic cause of pneumothorax at the moment because we're just not sufficiently advanced as a scientific community to understand that yet. And we're going to concentrate on the monogenic ones. So this is the sort of patient that I will be referred in the respiratory clinic. This was an actual woman who came. She was 68-year-old. She just retired from being a teacher overseas for several years. And she came in with left-sided pain. And hopefully you can see that she's got a pneumothorax. Can you see my cursor? Is my cursor going? Yeah. So there's a pneumothorax on the left. It's tethered, so the lung is stuck at the top. And that's because this isn't her first rodeo. She's had multiple pneumothoraces and chest drains, and that's stuck the lung at the top. So she's got this loculated pneumothorax. She'd started having pneumothoraces in her 50s, treated surgically overseas, and nobody had ever taken a family history. So it's interesting that she has the most dominantly inherited genetics of pneumothorax that you can imagine, dominantly meaning that you only need one broken gene. So her brother had pneumothoraces in his 40s, their mother had pneumothoraces in her 60s. Their maternal uncle had pneumothorax. This is a really dominantly inherited pneumothorax. And when she came in, she was very lovely, but she said, well, you won't be able to help me. This has been going on for almost 20 years and nobody's been able to find a cause. But in fact, it was very easy to give a diagnosis because on a CT scan, this is a CT scan reconstructed in a coronal way, so you can look at it like a chest X-ray. She has these cysts at the bottom of the lung, and I'll come to it in a second, but there's only one disorder that gives you basal cysts. And if you remember nothing else of my talk today, please remember this disorder I'm about to tell you about, because it's the most common genetic cause of pneumothorax, and a lot of doctors have never even heard of it, which is quite shocking. So when I examined her face, she had these little tiny white nodules on the skin. They looked like little white heads. She was really not, she'd noticed them, but she wasn't fussed because they were quite mild. But because of the condition I thought she had, I quickly arranged an MRI scan of her kidney. She had no renal symptoms, but she's already got a big tumor erupting from the upper pole of her right kidney. And sadly, she died within a year of metastatic renal disease. So what is this condition? The one condition I want you to remember today is Birt-Hogg-Dubé syndrome. Again, if we were in a room, I could ask you to put your hands up and say, has anybody heard of Birt-Hogg-Dubé syndrome? When I give this talk to respiratory doctors, hopefully now a smattering of hands go up, but most of them have never come across it and think it's rare. It's also autosomal dominant. About 90% of the patients who've got it get these cysts in the lower part of the lung. Half of them go on to have a pneumothorax. If you look hard enough, half of them have got the skin changes, but that's not why we make the diagnosis. The reason we make the diagnosis is because they tend to have a pneumothorax earlier in life and then 10, 20 years later develop renal cancer. And 25% of them will develop kidney cancer. If you make the diagnosis, if you in clinic just think about it and make the diagnosis of Birt-Hogg-Dubé syndrome, you can then arrange an MRI scan once a year for the kidneys, no radiation, and you will pick up these tumors when they are tiny, when they're less than a centimeter, and they're always curable. When, like this one, they're bigger than 3 centimeters, they're usually beyond the point at which we can cure them. So this is why I'm really, I'm really passionate that you try and start thinking about Birt-Hogg-Dubé syndrome whenever you see somebody with a pneumothorax and possibly they're either pneumothoraces in the families or renal cancers in the family. It's caused by a mutation of this gene called folliculin, FLCN. And if you read the textbooks, because they haven't been corrected yet, they'll say this is really rare. They'll say this is 1 in 200,000 people. That's pretty rare. We published last year the fact that that's wrong by about 100-fold. When we looked in the 100,000 genomes, we found that it's about a project. It's about 1 in 2,500 people. When we then looked at UK Biobank, because the 100,000 Genomes Project was a study of largely ill people, okay, and their relatives. UK Biobank was a study of 500,000 well people, and in half a million well people, 1 in 4,000 of them have Birt-Hogg-Dubé syndrome and don't know it, which is a stunning statistic. The UK Biobank is not very ethnically diverse. It's fairly middle class and fairly Caucasian. So we also looked at the East of London Genes and Health cohort, which is more ethnically diverse. And once again, it's less than 1 in 2,000. So it's more common than 1 in 2,000. So this Birt-Hogg-Dubé is a common rare disease. You will see it. It is the most common diagnosis that I make in my clinic. Again, somebody who's got this, they don't all have the skin changes, but if they have the skin changes, it's helpful. If you look at the CT scan and the cysts are in the lower zone, think Birt-Hogg-Dubé, and then get the genetic testing done. So that's the cause. Again, it's this mTOR pathway is a tumor suppressor. So when the gene gets broken, you're more likely to get cancers, but you're also more likely to get lung cysts. There is a related condition called tuberous sclerosis. It's caused by a different gene in the related pathway, well, one of 2 genes, TSC1 and TSC2, which are stand for tuberous sclerosis 1 and 2. This is about 1 in 10,000 of the population, and these patients have a variety of problems. Just like Birt-Hogg-Dubé, they have skin changes and kidney changes and lung changes, but different ones. Okay, so this lady has fairly dramatic skin changes, these facial angiofibromas. They're not always so obvious, but if you see these little dots on the face, if you're unsure, ask either your dermatologist friends or your clinical geneticist friends, and they'll be able to tell you whether they think these changes are going to be Birt-Hogg-Dubé or tuberous sclerosis. If you look on the skin, there are two types of skin changes, the most common of which are these hypopigmented region, the hypomelanotic macules that can be anywhere on the body. They're often described as being a little bit, not this one, but they're often being described as looking a little bit like holly leaves. They've got these sort of serrated edges. And sometimes you get these lumpy lesions called chagrin patches. Rarely, but it's quite obvious when you see them in the nails of either hands or the feet. If you get these little warty lesions growing out, they're ungual fibromas, subungual fibromas. So these are the skin changes of it. These patients can also get little benign lumps in the brain, which can give a majority of them epilepsy. So if you've got somebody who's got pneumothorax, changes of the skin, and epilepsy, think tuberous sclerosis. They can have learning difficulties, but many of my patients with tuberous sclerosis have no problems. In the kidneys, they can get these large benign tumors, and these large benign tumors can be quite sizable and need to be treated either by embolization or by surgical extraction. Now, but the reason we're talking about to them today is that if you've got this condition, tuberous sclerosis, you're more likely to have this cystic lung disease called LAM. LAM stands for lymphangioliomyomatosis. It pretty much only happens in women. It tends to get worse during pregnancy. So if somebody comes to your clinic and they're having, I think there might be some midwives on the call, you might have come across this. If a woman has a pneumothorax during pregnancy, think LAM, and it may or may not be in the context of tuberous sclerosis. So these cysts tend to be all over the lung. They're not just at the base, like Birt-Hogg-Dubé. And unlike the Birt-Hogg-Dubé cysts, which are a bit raggedy, these tend to be nice and symmetrical and round. You can see this woman has had surgery on both sides. The lung is stuck, but at this point, when we're doing the CT scan, this is one of my patients, she actually had bilateral pneumothoraces. So these tend to start during pregnancy. They can happen at other times, but pregnancy, pneumothorax, think LAM. Okay, so that's the mTOR ones. They tend to be cysts, skin, and kidneys. There's a whole group where you have defects of the extracellular matrix that's sticking the cells together. And everybody's heard of Marfan syndrome, or every medical student who sits in my clinic and I ask them what's the most common cause of inherited pneumothorax, they all get it wrong. They all say Marfan syndrome. Marfan syndrome just has a lot of good press. It gets into all the textbooks, but it's not the most common. It is important. It's a bit of a pig to diagnose because it isn't just straightforward. You see one set of symptoms and one set of signs, and you can say this is Marfan syndrome. It tends to be a whole host of things, and I've intentionally grayed out this list. This is the sort of sheet you need printing out to actually to remember these things, because none of us, even in clinical genetics, remember all of these things. But there are major criteria and minor criteria. And I've just given you an example. This patient, imagine this patient has a dilated aorta and they've had a pneumothorax. If you've had a major criterion, you need to have several of the minor criteria, but a pneumothorax counts as two criteria. It's so important. These patients, a little bit like the one that Kate was telling us, they have disproportionate arm spans. If your arm span should be within about 5% of your height. Think about Leonardo da Vinci's nice drawing of the man in a circle, same arm span as the height. This woman is presumably trying to show us the fact that she's got extremely long arm span. Kate also talked about arachnodactyly. Arachnodactyly just means spidery fingers. And some people just look at them and say, oh, they look a bit spidery. That's not good enough. You need to have these signs. Steinberg sign, or the thumb sign, is when you put your thumb across your fist make your fist around it, and if a whole joint sticks out the other side of the fist, that's a positive sign. That's a positive thumb sign. This is the most specific test. Murdoch-Walker sign, or the wrist, is where you put your little finger and thumb around the wrist. And when I'm giving this talk in a room, I usually see everybody doing this to themselves. And then a lot of the slim people get alarmed because the wrist sign is very easy to be, particularly younger, thin people tend to have a positive wrist sign. Don't worry about it. But if you've got that and the thumb sign, maybe give me a call. So Marfan syndrome, it's not that uncommon. It's about 1 in 5,000 of the population. 10% of them have these blebs at the top of the lung. Blebs at the top of the lung are the most common cause of random sporadic pneumothorax. But because Marfan syndrome patients tend to have blebs at the top of the lungs, they're much more common. They tend to have arachnodactyly, and they don't have to, have chest wall deformities. They can have it because when they're growing, their bones are quite flexible. And if they bend outwards, you get pectus carinatum, sort of bird chest with the sternum pushing outwards, or you can have the sternum pushed inwards, pectus excavatum, dug out chest. So chest wall deformities, apical cysts, long spidery fingers, think Marfan's. Again, we're not making the diagnosis because we want to be clever and show them why they've had the pneumothorax. It's because up to a quarter of them are going to get, over the course of their life, a dilated aorta that might need surgically correcting. And if you spot them early, you can give them drugs to keep their blood pressure under control, and that slows the progress. And also you can echocardiograph them every year. And when their aortic root gets big enough, then our thoracic surgeon colleagues can come in and reinforce it and prevent them from dying. So this is an important diagnosis to get because you want to make them live to a ripe old age. You'll hear people talking about somebody being Marfanoid. What they mean by that is the shape, the tall, thin, disproportionate arm span. That doesn't always mean Marfan's. There are a variety of conditions that look a little bit like that. And one of them we showed a while ago, back about more than 10 years ago, can cause pneumothorax, and that's the one called Loeys-Dietz syndrome. It's much more common. It's 10 times less common than Marfan syndrome. When it was originally described about 25 years ago, the patients were said to have very tortuous blood vessels all over the body, not just the aorta. Hypertelorism, that's when your eyes are unusually widely spaced apart. And they have evidence that as an embryo, their face didn't fuse together properly, midline fusion defects. If it's quite dramatic, they might have a cleft lip, but if it's mild, it might just be the dangly bit, the uvula, that isn't fused. And again, they can get all sorts of complications during pregnancies. A whole variety of genes involved in the signaling pathway, the TGF-beta signaling pathway. So when it comes to the genetics, very briefly, I'll show you, we've got all of these genes covered in our gene panel. So if you look in the back, it takes you a second to look in the back of the throat. And if you see this, if rather than having a nice uvula, a little dangly, they've got a bifid one that it just hasn't, it's telling you that their face hasn't, their head hasn't fused correctly when they were embryos. And that's because the TGF-beta signaling pathway wasn't working properly when they were developing. So this was, in one of my patients, was the clue that she had Loeys-Dietz syndrome. And because you're probably boring you now, I'm going to go one more disorder, but you really need to know about this one as well. It's probably the rarest of the diseases we're talking about today. It's only 5 cases in every million, but vascular Ehlers-Danlos, not just Ehlers-Danlos. There are many patients with Ehlers-Danlos syndrome who are a bit hypermobile, who aren't going to come to real harm. Vascular Ehlers-Danlos is a specific subswarm caused by mutations of the collagen 3A1 gene. Collagen 3A1 is a part of the extracellular matrix that holds together lots of your hollow structures, blood vessels, lungs, uterus, bowel. So patients who've got these collagen 3A1 mutation causing vascular Ehlers-Danlos, they can suffer from rupture of any of those structures. They can have ruptured bowels, they can have a ruptured uterus, they can explode their blood vessels. That's why 80% of them have suffered a life-threatening complication by the time they're 40. So if they're lucky enough to have a pneumothorax and see you, and you make the diagnosis, you can then help introduce treatments which will prevent some of the more dangerous life-threatening. Now, how are you going to spot them? Like a lot of the connective tissue disorders, they can have a high arched palate, so the palate is way up in the chest. These patients tend to be quite hypermobile. This is somebody who's about to touch his thumb to his wrist. That's his thumb. If you can touch your thumb to your wrist, you're a bit hypermobile. They tend to be able to extend their tongue. And if you look at any old scars, if the scars don't hold together but stretch like this one, this suggests there's a problem with their collagens. If you have never measured somebody's, and I'm sure the physios on the call will be very used to this, but for everybody else, if you're not measuring, if you're not used to measuring somebody's hypermobility, it's actually quite easy. It's a score out of 9. And you're allowed up to 5, but generally only sort of young women will get up to about 5. Most of us will get to 0 or 1. So you get a point if you can touch either of your thumbs to your, at one point for every thumb you can touch onto your arm. That's 1, 2 either side. If you can hyperextend your knees, so if your knees bend backwards, old-fashioned sort of double jointed, then you get 2 more points, 1 point for each leg. Another for each elbow. If you can, when you try to straighten your arms, if they bend further backwards, more than 10 degrees backwards. Same if you can hyperextend your little fingers. So we've got, 2 for your thumbs, 2 for your knees, 2 for your arms, and 2 for your little finger. The last one is being able to touch the ground without bending your knees, but you only get the point if you put your palm on the ground. Many people can just about scrape with their long fingernails, but you'll see this patient is showing that she can bend over. Some patients bend over and put their elbows on the ground. That's how mobile these are. That is hypermobile, not just being a little bit. If you've got more than 5 points, you're hypermobile, and you should start thinking about vascular Ehlers-Danlos. So this is one of my patients we wrote up a few years ago with vascular Ehlers-Danlos. He was coughing up blood, as some of these patients cough up blood, and developing pneumothoraces. And when we did a CT scan, all of these little sort of shadowy areas with a hole in them, they're little cavities. And when you look at them, most people, and I'm just as bad as, most people will look at these and think this is a vasculitis. This is one of those conditions where the blood vessels are inflamed and you need to immunosuppress them. When you go on and do a lung biopsy, there's no inflammation, but there's evidence of recurrent bleeds. These are cells with broken down hemoglobin in them, in the airways, and areas of fibrosis. And this is vascular Ehlers-Danlos. Again, these patients will come to harm later, in not so long in the future, if you don't make the diagnosis. So if in doubt, just raise it as a possibility. So nearly finished. We're on the home straight. So a few years ago, Hannah Grimes, another medical student, she's now a genetics trainee, went through about 490 patients in my clinic, and she made a very interesting observation, is that the patients who have a family history of pneumothorax, whether we get a diagnosis or not, tend to recur more quickly. So something about familial pneumothoraces tend to recur more quickly. So it may be this is something we need to continue to study. But it might, when you're counselling them about the risk of recurrence and when it might happen, this may be relevant. She also looked at the diagnoses we made, and you can read her paper in Thorax. You'll see half of the diagnoses that are made in my clinic are Birt-Hogg-Dubé syndrome. So please, please, please remember Birt-Hogg-Dubé. Yes, we see some Marfans and Ehlers-Danlos and Loeys-Dietz and then rarities, but this is the most important one. The work that Hannah and I did in the 100,000 Genomes Project came up with this list of genes, and this is now the R190 gene panel that Anita showed you right at the beginning. And the way I wrote the request is that it doesn't have to be requested in the genetics clinic. It can be requested it can be requested by a doctor in the respiratory clinic as well. You know, the days when every genetic test had to go through a clinical genetics clinic are over. These are diagnoses that we should be making in general respiratory clinics as well. So I want to thank the 100,000 Genomes, because that's when we were working with when we invented that test. If you're interested, we have an MDT every 2 months, and that's run by and I chair this. And your cases, you can just contact us, and we will discuss them on this online MDT. And or even if you're just interested, just contact us, and we'll give you the link. And we're doing lots of basic research funded by LifeArc. I think, yeah, I don't have the QR code, but I think Anita has the QR code to allow you to find our website and our email addresses, and my email address is there if you want to contact us. If you've either got any patients you want us to discuss, or if you just are interested and you want to learn and treat our MDT as a learning experience.
So the R190 gene panel, so do we can just fill in like a paper form and send it within our own internal pathology departments?
What I tend to do is well, I don't know how it works in your hospital, but for us, it's easier for us to ask when I see a patient and they've got a familial pneumothorax. It's always nice to discuss it with a clinical geneticist, but the clinical geneticists do not have to see the patient. But it's nice to get their blessing. It makes them feel good, and they're nice people. So I know this has been recorded. So they are nice people. But I say store some DNA. So if you send them for your lab, ask them just to extract DNA and storage. Tell the patient, I'm not going to use it until I've spoken to genetics. Then when the geneticists say yes, then you can contact the lab and ask them to do the test on the stored sample. That avoids the patient having to come back. So your lab should be able to know how to store DNA. And then you just, but the test, the genetic, again, people on in this audience probably know this better than I do, but these gene panels are done in different parts of the country. If it's being done as the R190 gene panel, your lab will send it up to Sheffield. That's where the R190 panel is done. But they need to have some DNA in the freezer.
Lovely, thank you. We've had a question from Catherine. She said, has a diagnosis been reached for the two brothers, or clinically, which diagnosis is most likely?
So I referred them to the MDT just last week, so they haven't been discussed yet. And then I've written them a letter to see if they're happy to be seen by Stefan face-to-face or as a clinical review. But I don't know if you've got any thoughts on them, Stefan.
Yeah, I'd like to see them. So for everybody, there is... Yeah, I think I removed this slide for length, but we have an MDT pro forma. So if you contact us, when you see us, there's just a 1-page form, and we ask for things like the height and the arm span, and if they've had an echo and if they've had a CT scan. And we don't expect everything to have been done. So I wouldn't not refer somebody because it hasn't been filled in. From that, when we discuss it and we look at the CT, we often have an idea. With this person, I think those brothers, they look as though they're in the middle group, the connective tissue group. But without actually seeing them, it would be difficult to actually say. But because there's 2 of them already, they qualified for genetic testing. So we'll discuss them at the MDT. There may be something that comes up in our discussion, because we have geneticists from Cambridge and Glasgow, and also other people dialing in, who'll be able to give their opinions. But what we'll often say at the end of it is send the R190 gene panel, which can either be done by my clinic or your clinic.
Lovely, great, thank you. We've got another question asking, Stefan, could you explain how the skin changes may appear in someone who's got brown or black skin with people with Birt-Hogg-Dubé syndrome?
Yeah. So again, there are these. So the lumps, the little lumps, they're called fibrofolliculomas. They're actually a variety of benign tumors that they can get, because they're benign tumors, but the fibrofolliculomas are the most common. They're benign tumors that come from the base of hair follicles. So on paler skins, they look as little white raised nodules. Sometimes they can be quite large, and sometimes the patients will be diagnosed by the dermatologist because they've gone to the dermatologist because they said, I've got all these warts growing over my face, and then the dermatologist will take them off and find out that they're fibrofolliculomas. In people with darker skins, and I have got some patients in my clinic with darker skins, it's similar. You see these raised little lumps that tend to be paler than the surrounding skin.
Lovely. Thank you very much. I'm just checking. Oh, we've got one more question come in. Can you advise what age people are usually, or what age people are usually presenting with familial pneumothorax? This is from a paediatrician.
Yeah, it's a really good one. My clinic, the pediatricians in Cambridge tend to send me all of their pneumothorax patients to follow up as well. So I would say my clinic tends to have children as young as 10 or 12 up until sort of 80s or 90s. I think I've diagnosed a Birt-Hogg-Dubé patient in her 90s. She had many different tumours during her life, which were opportunities to make the diagnosis. So we do see families or children with familial pneumothorax, but we don't genetically test children until they become adults. It's not going to alter our management. If they have an older relative, so if they've got an old uncle who's had a pneumothorax, we can test him, but we don't test the children until they are usually 18, when they can give informed consent. But yeah, if the child comes and an older relative has a pneumothorax, you can make the diagnosis by testing the older relative.
Lovely, thank you. I think that is it for questions at the moment. If anybody has any more, I've just got 2 slides to share. So while I do that, I'll give you a chance to think. We're just going to finish, bear with me. Again, I'm obviously sharing the QR code for the feedback form, which obviously helps us on planning further events. And then for those of you that are interested in learning more about genomics, there's been many more sessions before this, and we've gone back to basics, which you can are available via our website. The links and QR codes are on here, and the slides will be shared as well. And then finally, here's the link for the Rare Disease Collaborative Network for familial pneumothorax that Stefan mentioned earlier. You can scan that QR code. There are also links to the Genomics Education Programme and to GeNotes, which are also aimed at clinicians, and they give you much more information around genomics if you want to learn about that in general. That's as much as I need to share for now. I'll just stop sharing and make sure there are no more questions in the chat. Nope, I think that's it. Lovely. Again, thank you very much, Kate and Stefan. Really appreciate your support today. And thank you to everybody for attending.